Welcome back. You may not know what the Atrial is, but it might save your life, especially if you're prone to atrial fibrillation. Here with the details is cardiac electrophysiologist Dr. Dan Goldman. Dr. Goldman, it's great to have you on the show. Welcome.
Thanks, David. Thanks for having me.
And you brought props.
I did bring some toys with me.
Which is great. All right, we've got the Atrial, we've got stroke, we've got a lot to talk about, but I think we should start talking about atrial fibrillation, which is kind of the impetus behind all of these other things, right?
Yes, it is. Atrial fibrillation is actually the most common arrhythmia that we deal with in the heart, or abnormal rhythm of the heart. And it's when the upper chamber of the heart quivers, actually. Instead of nice, smooth contraction, it's quivering. And the biggest risk of that quivering is blood doesn't move normally. If blood doesn't move normally anywhere, what does it do? It clots. People who get clots in their legs because they were on an airplane for too long, not moving, sedentary, whatever, same idea. Well, the problem is that these clots can form in a little pouch in the heart, and I'll show you that in a second. And if a piece of that breaks away, it goes right out to the aorta. And if it goes out to the aorta, it can then go to the brain and cause a stroke. It can go to the liver and cause an infarct, go to a limb, etc.
Okay.
So the biggest risk of atrial fibrillation is what we call an embolic episode.
So who's at risk to get atrial fibrillation? Is it can it happen to anybody?
It can happen to everybody. There are some risk factors. People with valvular disease can be more likely to have AFib, but just people with no other problems, as you get older, the rate increases. And the reason it increases is because the actual changes in the heart muscle. It degenerates a little bit in that upper chamber, so the conduction isn't normal, and it gets a little scar here and a little scar there, and then this rhythm is allowed to form. And we actually see it very commonly, and it increases significantly as patients get older, particularly over the age of 80.
So can somebody be walking around with atrial fibrillation and not know it? And then as a follow-up to that, what should we do? Should we all be getting EKGs regularly?
That's a good question as well. Yes, you can walk around with atrial fibrillation and not know it. And unfortunately, some of the times we first recognize AFib when patients come in with a stroke. So that's obviously a problem. People should get a regular physical exam. I'm not going to tell everybody to run out and get an EKG. You can feel your pulse. It'll be irregular, but other things cause irregular pulses. So that's not a good indicator. If you have any symptoms, obviously, a stroke, you need to be seen immediately. Anyway, so people should have regular EKGs, regular physical exams, and
there you go. Okay. So now that brings us to the Atrial. I'm going to have you talk us through it. I'm going to stop talking. You're the expert,
Okay.
So tell us what we have here.
So the issue is that in the left side of the heart, there's a structure called the left atrial appendage. It's actually this small sac, and it had to do something with embryology. It's not that important once we get out of the womb and get going. But the problem is it's a little sac. So where can blood form? Nicely in this little sac and just sit there and form a clot. If it breaks away, it goes out the aorta up to the neck, the head, the body, etc. So the biggest thing we want to do is prevent a stroke. There are a couple of options. The most common option, and it's been going on for many, many years, is to anticoagulate patient. We put them on a blood thinner medicine, and it makes them much, much, much less likely to have a stroke. They could still have a stroke, but they could also have a bleed, which is one of the problems with using the drug. Particularly if you're on those drugs and you fall and hurt yourself, you can get a bleed in the head, etc. Mm-hmm. So that's the biggest prevention we have, or the most common for many, many years, was to put people on blood thinner medicines. The problem is that everybody is not a candidate to be on a blood thinner medicine, and that's the patient.
Why would you not be a candidate for that?
That's a good question. And the patient that got this started is a gentleman who had had a history of atrial fibrillation that came and went, and he was admitted to the hospital about 1.5 years or so ago with a bleed in his head and a headache. And the number that we used to measure the actual level of blood thinning was perfect. So it wasn't like he was over blood thinned or under blood thinned. It just happened, and it's one of the side effects of the drug. So he could no longer be on those drugs. Well, we were able to give him medicine and keep him in a normal rhythm, put him on a little aspirin, which gives you some protection. And then he came to me a few weeks ago, and lo and behold, back in AFib, and now we've got to decide what to do. We know that he's not going to get out of AFib because he has valvular issues and other problems, so we've got to decide how to prevent a stroke. I talked to the neurologist and the neurosurgeon, and they said absolutely not, cannot be back on blood thinners. Okay. So we were stuck.
Okay, so which brings us to what you did for him.
So the next step we felt, which was very exciting because this is a relatively new technology, was to do something about this left atrial appendage. And that's where this clip comes into place. And this is actually called the Atrial. It's a device developed by a cardiac surgeon, as a matter of fact, and it's put in by a cardiac surgeon through small incisions in the chest. And it goes on the actual appendage, and then it's released. And then with another trigger, we can actually cut the sutures. I'm not going to do it on this one.
Right.
And then it's left in place. And this is actually what it looks like when the clip is in place. And it's nitinol clip with springs and covered with a non-thrombogenic cloth to protect the patient as well. And it's put on. A tube is put in the chest. This patient had this done about 3 weeks ago. The chest tube came out the next day. He went home 2 days later, and he was off to St. Augustine for the July 4th weekend.
How effective has it proven to be?
Doing something about the appendage is found to be very effective, and the clip has been found to be very effective. In the old days, a surgeon might have to staple it or sew it. That could be incomplete and hard to document, and sometimes it would actually reconnect. Whereas when this goes, it closes it off very well, and the appendage is just absorbed by the body and goes away.
I know with valve replacements, oftentimes you have to get them re-replaced, I guess, if you will, every 10, 15 years, whatever.
Correct.
What about this?
This is permanent.
Oh, it is? Okay.
Yeah, this is absolutely permanent, done, finished.
I know there's I would imagine, no such thing as minor heart surgery, but how complex is this surgery? How long is it? What's the recovery like?
That's a good question. This was done by Jeffrey Newman, who's one of the cardiac surgeons at Delray Medical Center. I referred him to him. And the procedure takes about a half an hour, 45 minutes. It's made with a couple of incisions in the lateral chest, and a tube is placed. And they can actually do it with a camera as well, which was used to assist his. It's relatively minor, to answer your question, as chest surgery goes.
Really fascinating. Thank you so much for coming on.
Thank you. Thanks for having me.
If people want to get more information about you or where you practice or this, how do they do that?
I'm with the Cardiology Center. I'm in Delray Beach. My office is right across the street from Delray Medical, 16244 South Military, 561-495-7787.
Rattle that off.
Thanks for the opportunity.
Like a pro. The last thing, actually, before we go, is just any advice you would have for our viewers with regards to better heart health care.
You know, I think, and we do this all the time, and the good news is that more and more patients are really paying attention to it. These are all fancy, wonderful devices and things to offer people, but really what you do for yourself is the most important thing. Controlling your blood pressure, watching your diet, and getting exercise.
All right. Well, thanks so much for coming in.
Thank you.
Great to have you. All right. Thanks a lot, Dr. Goldman. That is all for our show today. I hope you enjoyed it. And if you have any ideas as to what we should cover, all you have to do is tweet us at WSFL. You can also follow us on Facebook at SFLCW, and of course on our Facebook page, Inside South Florida. That's it for this week. We'll see you again next week. And remember, of course, you can catch us every weekday on Eye Opener from 6 to 8 a.m. right here on SFL TV. Have a great day, and I'll see you soon.